Hello to all of you. My name is Peter Albers. I'm chair of the scientific committee of this year's EAU meeting. We are now having a small conversation on screening issues that have been presented at this year's EAU. Major trials have been released and we have a lot of things to discuss. But first of all, I would like to introduce my colleagues for the discussion. First of all, Professor Monique Roobol from Erasmus Center in Rotterdam. She's an epidemiologist and chair and lead and chairman of the ERSPC trial and now leading the PRAISE-U project of implementation studies in screening in Europe. Then we have André Deschamps, for many years patient representative working together with the EAU. I think this is a very important aspect that we have to discuss now. And last but not least, Professor Anssi Auvinen from Tampere in Finland. He's leading the largest screening trial at the moment with a mortality endpoint. And the latest results have been presented this morning, and we are very curious to hear about that. So, but first of all, I think when we talk about screening and detecting of prostate cancer, we'll have the Lancet Commission, for example, today here at the EAU, which was in the public media yesterday, and they claim that we have a doubling on incidence in the next 20 years. And also a doubling of mortality worldwide. So prostate cancer is a big issue. And that brings me to the fact that we need to discuss about early detection. It's not about treatment. I think it's on prevention of this disease and early detection. And so the patient perspective is very important in all this. So when you talk about screening, heard about these screening trials this morning, what was your impression, André?
Yeah, well, first of all, I think we need screening. And the reason that we need screening, as a patient representative, I've seen, and I've had many friends dying from prostate cancer, from metastatic prostate cancer. And if you see what's happening with those patients, if you can avoid that, avoid it. And the UPROM study showed that there is a big burden, a huge burden once you are in the metastatic phase. So I would say what screening should do is, first of all, avoid that patients are coming into the metastatic phase. Now, the flip coin is that if we go to screening, like this morning was quite rightly said, we have a passport of being a patient. So try to avoid that we have a passport of being a patient due to how you do the screening programs. If you need to treat us rather in an earlier stage. Well, if you can avoid treating us by active surveillance, then we only have the psychological burden. If you treat us in the first phases, we have a substantial sexual burden and incontinence burden. But for God's sake, avoid the metastatic phases. But then our burden is even tripled. Yeah? And we die. So those are this is my view. That should screening do.
Yeah, that's a real dilemma we are running into. Today we had the presentation of really major trials. It started with the CAP trial, 15 years. Very realistic that it doesn't make sense to use one PSA value. Huge data. Then we had the PRIME trial of a special way of how to use MRI imaging. Then your trial with ProScreen and ours from ProBase. So Anssi, what would you summarize from this morning as more or less take-home message from these large trials that influence our future strategies?
I think we are making progress, but yet we don't have the answers. So I very much agree with Mr. Deschamps' point that for screening, we must show first that we reduce mortality and we should pay close attention to the quality of life effects. Avoid overdiagnosis and not accept the sort of technological shortcuts as the solution. But we need really empirical evidence from randomized trials that show what can we achieve, what is really the balance of benefits and harms. When should we start screening, for instance, from ProBase trial? Should we use biparametric or multiparametric screening as from the PRIME trial? And then from the Göteborg 2, from ProScreen trial, what is really the impact of screening on detection of low-grade disease, which probably means overdiagnosis, but we don't know for sure. what is the impact on high-grade disease, which probably is a promise of mortality reduction, but we don't know that for certain. So I think we are sort of making progress, but we are not there yet.
What about biomarkers? In your trial, you also use 4K. Before you're using MRI, you showed us that it seems to be that you can select more for the high-grade aggressive cancers by this, but there are multiple biomarkers on the market. So first, why have you selected 4K, and do you really believe that this is the way to go to reduce MRIs?
Well, if you compare, for instance, Göteborg 2 that uses PSA followed by MRI, then I think the result from the ProScreen and also Stockholm 3 suggest clearly that it makes sense to have one reflex test in between, because the balance of high grade, low grade seems more favorable. But I think we also had a presentation about the different biomarkers, and there was no real winner probably. There was some suggestion, also our rationale for choosing 4K, that it might function quite well in a screening setting. We really need to minimize the numbers of men referred. But there's probably no one alternative. And we also have the risk calculators, which are probably less costly option than taking commercial biomarkers. So that is also something that we don't have a certain answer.
Perhaps I also can direct this question to Monique. It is clear that we also have now to come down from the large numbers of MRI, which are at the moment published. On the other hand, what I'm missing is the long-term observation of those that don't get diagnosis. And now I'm presenting this pro-based population with 45-year-old. They have 40 more years to go in average. Yeah. And if we diagnose an ISO 1, and this is one of your messages and the messages of most other trials, we should not diagnose ISO 1. ISO 1 at age 45 may be completely different from other diseases. So you have major experience. You have shown that at least mortality reduction is possible. And what do you think about now about the harms of these approaches?
Well, it's obviously what the harms were in ERSPC, where we have this very, very long-term follow-up and where we showed this mortality reduction, and perhaps even more important, showed the reduction in metastatic disease by almost half, so 50% reduction. But what we also have in ERSPC, and this might be perhaps some people would say ERSPC is an outdated trial, it's old-fashioned. But what we do have is the long-term follow-up of those considered low risk. So we are constantly following those people over now almost 30 years. And we learn a lot from that. And we know now, like you told for your pro-based trial, that men with low PSAs are indeed at very low risk. And now even perhaps at a very young age, we already know that from the older ages. So that will bring us constantly more information because we keep on tracking down these people. But I do suggest that, like you say, that in the more contemporary trials, this is a very important issue. And they should not stop after having diagnosed Gleason 7 or higher cancer or having 5 years of follow-up, because they need to continue. And it is for us crucial to keep track of all those long-term follow-up data. But on the other hand, I would like to stress that it does not mean that we have to sit and wait until another 10 years or another 15 years, because there are men living now in Europe. So we need to take action, and we are awaiting this tsunami of prostate cancer. So it is also time, on the other hand, to act as soon as possible and try to streamline on the basis of what we know already. That's my view on this.
This leads me to another question to all of you. In my personal view, mortality, which is your endpoint, is also shifting away. If you see now the data for lymph node metastatic patients now living 10 years and longer, but they have a lot of burden of disease because they need constant hormonal treatment. So my view changed over the last years that metastatic disease may be not only a surrogate endpoint, but maybe even an endpoint, primary endpoint of screening, because then the burden of treatment starts and people suffer from side effects from systemic treatment or hormonal treatment and suffer from the burden of really being treated.
I love that. I mean, that's exactly what I was trying to say. And Monique said it just a few minutes ago. Doing nothing is not an option. I mean, I think with the knowledge we have now, if you compare that to the knowledge that we had 5 years ago or 10 years ago, we can start with programs. Will they be perfect? No. I accept that they are not perfect now. Do we need to improve them? Yes.
That's a constant improvement,
But
right? Yeah.
there is a tendency to say, let's wait till we have in 10 years or in 15 years all the results. Please don't do that.
But on the other hand, the concept of metastatic disease is changing also. And as Freddie Hamdi, for instance, said, we have non-lethal metastatic disease as a new entity based on, for instance, the new imaging methodologies. So probably I think the quality of life impact will be something that will be very important, because if we have metastatic disease that's only radiologically detected and doesn't impact on the man's quality of life, then that might not be that important. So I would emphasize the quality of life results in that respect.
Yeah, that's true. But once you start to have ADT, your quality of life is going dramatically.
Agreed.
Exactly.
But this should actually be proven. And when we remind ourselves on the PROTECT data, 20% of those had clinically relevant metastatic disease. So they need indwelling catheters. They had to be treated. They could not void. And obviously that they were not dying. So the message that all treatment options are the same in terms of survival, this is correct. But many of the active surveillance populations had treatment phases of 10 years and longer in this trial. So I think quality of life, I think you're right, because the landscape in treatment of lymph node, for example, metastatic patients, completely changing at the moment from local treatment to systemic. Not everyone needs systemic. But I think we, as a research community, should think about quality of life and what we really end up with when we start a screening program. And it's not only dying from prostate cancer, it's really suffering from the whole disease. And
Yes, exactly.
Monique, what is the solution for this in the future? Because you're now planning new screening trials.
Yes. And let me be very clear. The screening trials that we are planning within the PRAISE-U program are no randomized controlled trials. There are no studies. We are really looking perhaps already upfront and anticipating the future, what is needed in each country to actually start thinking about implementation of a population-based screening program. And we now know already for sure that while there are studies running and they're trying to look at different algorithms, there will not be one specific European algorithm. That will not happen. It will be highly dependent on the country in which we are living, what is possible and what is financially possible, logistically possible, what is acceptable due to cultural reasons, whatever reasons there are, political reasons. So what we are doing within PRAISE-U is starting implementing population-based studies. And we all know that we should risk stratify. We have, like Anssi just said, several biomarkers, risk calculators. They are all more or less performing similarly. So the choice will be dependent on other factors, not on which is the best. No, it will depend on other factors, which is acceptable, which is feasible, which is financially acceptable.
And also, I think probably prostate cancer is much more of a priority in Northern Europe with high mortality compared with Mediterranean countries with low incidence and low mortality. So that obviously needs to be taken into.
So this is what we will do in Europe. Try to look in Europe, implement population-based pilot studies, learn from those. And in the meantime, the studies will develop, will give data. We will look at those obviously constantly. But we are trying to prepare to actually start population-based screening, because not only for the tsunami, what is coming. I'm sure, I'm convinced what will happen. We will get an enormous amount of prostate cancer diagnosis, but also then to stop all the opportunistic testing and the high diversity in how this is approached. Even within regions, within cities, it is even different. So hopefully we can end that with a more controlled plan of prostate cancer detection.
To be honest, this troubles me most. We have seen participation rates of these intelligent programs in the area of 30 to 40% only. So what gives us the hope that the opportunistic screening stops when an organized program starts? Even in Finland, I would say Finnish people are well adherent to this perfect trials. They get an offer. And I think 50% was the participation.
51.
51%. But still, isn't this a problem that we have intelligent, risk-adapted ideas and no one comes?
And for instance, in Finland, the participation in prostate cancer screening is lower than for mammography screening, and so it must be something with risk perception. But also, as you said, if we offer screening for men, let's say, age 50 to 69, then I think we would need to be very confident that it does not mean that men outside that age range will get more opportunistic screening. So that's a real dilemma.
Yeah, it is a dilemma, but I do think if such a program would exist and the clinical care would say to a man that seeks screening, okay, I'm not going to help you. There is a program in place. You go to that program, then we might solve the problem. And awareness, obviously a lot of awareness, and it's very difficult. And saying as a woman, it is very difficult to convince men to participate in any medical adventure.
But one way, let's take colorectal screening. And I think this is a brilliant example of high acceptance rates, because you get the message with one coloscopy, 10 years you don't have to do anything. And this is pretty sure.
Yeah.
And even where you don't have an organized program, then you have diagnostic coloscopies, but still the message is the same. And this is adhered to. And I don't see this in prostate at the moment. They get the message, well, take a 1 PSA value, and then you don't have to come 5 years, and they still come because they are not convinced. So, André, what is the problem about this?
Well, the problem about not going for screening is also a cultural thing. Yeah, because we also have seen it in all the studies that we have done. The more you go south and the more you go east, the less people answer and are really interested in that. But I think you cannot avoid that. A way to do it, in my view, is go through the women. And that is why we have now done what is the burden for the couple, what is the burden for the women. So if you can make the couple aware that there is a problem, if you don't detect it, then you have, in my view, a better chance. Because we men are not very good in going to doctors.
But I was talking...
Much better. Yeah.
To interrupt, I was talking about the opposite, that you go to a first screening and then you're a low risk. And you're gonna told, well, you don't have to worry, you will not get prostate cancer. And there's no confidence in this at the moment.
Well, it's also very easy to get another PSA test, not a colonoscopy, right? So it's also the ease to get another blood test. And it is facilitated by perhaps GPs that do a yearly checkup. They just add it to the form without telling the patient. So we need a cultural change. We need more awareness and education.
And better communication, because in your trial I saw 15% took a PSA in the control group, when I was right.
Close to.
And in our, it was at maximum 25, including all the familial patients that had familial hereditary cancer. And I think this is not a group where we have to design a screening program for, because they will not behave at all. But the others, if it is in the range of 20%, that they really stay away from further testing, this would be a success, I would say. This is kind of a communication we have to work on. And now we are back with Praise You. I think these simple things, who is inviting, who is taking the blood, who is communicating the blood test, who is re-inviting, This has not been tested overall, and we don't know the solution, what is best. So perhaps you can give us an insight on
we're going
your planning.
to test this actually in PraisU. So that's why I very much like that the pylons are so different from each other. So we have home-based testing. I'm extremely curious what that will do with, let's say, a response rate. And obviously we have a strong quality control component needed there, but it is something that we will test. It's a test phase. I'm really looking forward to see the outcome of that. And obviously we have very good developed communication, and we aim to follow the men. And we also have repeated questionnaires during the screening steps, also for those that decide not to participate anymore. So we really want to learn what is happening in the heads of the men. Why do they do this? Why do they do it not? And hopefully we can learn a lot from that, because like Anssi said, it is quality of life that in the end will be extremely important to determine the effect of the screening. But it is also much earlier, why are men not, or why are they participating? And what is happening, because we have a strong component also that men get an invitation for participating in the screening program. And a lot of these men take all this information, go to their GPs, for instance, ask for advice. So we have another job to do, is to educate the GPs.
That is my last point, and I would like to have an answer of all of you. These are healthy men, and most of them will stay healthy. They will not get prostate cancer. And at least in my country, the system is that prevention is mainly managed by healthcare providers, which means doctors, and they're seeking for diagnosis, they're living from diagnosis. So in an ideal setting, and I think this is in Scandinavia for the time being, where you have prevention boxes and people are far away from doctors as long as they are not really patients. And I think this principle has to be tested in implementation trials. So even we are now testing a self-test for PSA in the pharmacy instead of going to a doctor's appointment, because the waiting times are so long, and then he looks for several other things. A comment on the situation, self-testing, being impatient, being healthy.
The point I'd just like to make is that I don't think we should aim at maximizing attendance. I think we should be maximizing the informed decisions, and so that the men are fully aware of the pros and the cons, are able to sort of adjust their decisions to their preferences. And I think we are not doing very well in that front.
I think that awareness of prostate cancer today is very low. And why is that? If you try to go to the press and you have an article about prostate cancer, they look at it with big eyes, and if you're very lucky, they publish. If you do that for breast cancer, everybody jumps on it. So there is definitely, I'm not comparing breast cancer with prostate cancer. I'm just saying the awareness of the big male cancer, the prostate cancer, is so low that is what we all need to change. And I think with a population-based screening program, you must do that, because if you don't do that, the adherence will be very low.
Very low.
I think we have to stress what Anssi just said. It's not adherence to a program, it's adherence to informed consent, so that everyone can decide, do I really want to be screened, and what are the pros and cons? And this needs a lot of communication.
This is very challenging, because we know now that those people that do participate up to now into studies and so are the more privileged people, the high SS people. And what we actually want in a population-based screening trial is also those men that are at a lower SS, are not so well educated, but are perhaps at high risk because they have an unhealthy lifestyle. And getting those to a fully informed consent is the biggest challenge ever.
Actually, this is what is in this publication from Lancet Commission. They are going for inequities in also for screening. And it's very sad to say, but those groups that have the highest risk to get prostate cancer are sometimes those with the lowest income and uninformed. So this is a major challenge for the future.
It is.
And personally, I don't understand why the politicians don't pick this up, because it's so expensive what we do now that everyone does opportunistic screening, and only the well-informed people can afford MRIs and whatever, and the rest is just not taken care of. I think this is a major problem in most of the countries.
And especially if they start looking at national statistics and say there's nothing happening. But if you totally ignore the population that is at highest risk in your country, nothing will happen. So, it's a difficult situation, but we really must work on this. It's top priority. Also in PraisU, in the pilots, we have countries where we also will screen in cities, which is already different, but we will go to very rural areas and try to connect to those people, which is a totally different ballgame, actually. If they have to travel, for instance, for 30 or 40 minutes for their PSA test alone, I won't go. So very different challenges everywhere. Yeah.
So I think as a summary, we have learned a lot this morning from major trials. I'm very glad that we all work together in Europe and not against each other. So we can complement many data, and not everyone has to test everything. And so in the next years with upcoming data, and we'll have a different situation, probably better, and implementation will play a very important role. And so I thank you all for this very interesting discussion.
Thank you.
And
it was a pleasure.
see you later on this meeting. And thanks EAU for giving us this opportunity.